the next group, I think we're going into the 4 o'clock hour, and the Indian experience with core valve is the next speaker is Dr. Anantharaman, and
Obviously, this is about the importance of self-expanding evolute in small aortic annulus. Now, before we go into that, let's sort of clarify some of these things. What do you mean by small aortic annulus? How do you define it? And why is it important? What is the significance of this small aortic annulus? And then subsequent patient process mismatch, how does it affect? And when you have such patients, how you select your TAVR valve, what is the evidence at the moment, and what should we do? And then just a quick case example. Now, small aortic annulus, this is from Bibart. It's a well sort of put together document, basically a mean aortic annulus of less than 21 millimeters, whichever way you derive, either by perimeter or area derived. The annulus we are talking about, as we are in the transcatheter world, is the virtual annulus, that is the nadir of the three cusps. And that is the annulus. If it is less than 21 by any of these imaging modalities, then it is small. Now, why is it significant? Obviously, any longevity of our results with bioprosthetic valves, either it is TAVI or SAVR, it depends on your procedural mortality, stroke, paravalvular leak, access issues, pacemakers, and then subsequently the performance of the valve. How does it perform in terms of the gradients, orifice area, structural degeneration, thrombosis, etc. Now, this is kind of a fantastic curve that is shown here, the normal valve up to 4 centimeters square. But anything below 2, then patients will start to have symptoms. There is a time they start to have symptoms, especially on effort. But if you see most of the prosthetic valves, it gives you a valve area of about 2.2 to around sort of less than 1. So it's very important that you select the right valve for your patients based on the body surface area. This is our very early data from the partner one, showing that irrespective of whether it is SAVR or TAVR, when the aortic annulus is small, their outcomes are very poor. When the aortic annulus is moderate and large, it's slightly better. For TAVR, it's mostly, obviously, paravalvular leak is quite high in the TAVR group compared to the SAVR, because the surgeons will sew it and they will very minimal kind of paravalvular leak. And the outcomes are the same. For the small annulus, the outcomes are worse. So this is what is shown in SAVR. Obviously, the patient process mismatch is high, but the paravalvular leak is low, and the opposite is for the TAVR. So it does affect the mortality. The multivariate analysis has shown that there's a 1.8-fold increase in mortality if there is a severe patient process mismatch, and a 1.2-fold increase if there is a moderate patient process mismatch. It also affects the structural valve degeneration over a period of time, about 2.3 folds. So it's a triple trouble. Obviously, you have severe patient process mismatch, you have mortality, you have heart failure, you have structural degeneration, and also it's more so for the valve-in-valve cases. So this is what the data has showed: a 1.8% increase in mortality for severe PPM, and 1.2 for the moderate, and 2.3 in terms of moderate severe PPM with structural valve degeneration. So the severe patient process mismatch is if it is less than 0.65 centimeters square, and mild to moderate, it falls between 0.85 less or more. So what are the options? If the surgeons are doing, they can root enlarge, or they can select a newer device. For us, for the transcatheter, we need to know which valve we are going to choose. Over a period of time, the valves have evolved, especially the evolute have evolved to such an extent that the mortality rates come down to comparable to the surgical and all-cause mortality, and paravalvular leak is significantly reduced with the current generation of evolute with the outer wrap, evolute pro. And the pacemaker rates is also fantastically low with the new implantation techniques. So how will we select our TAVR valves for the small annulus? And this is a very important slide which shows that the self-expanding evolute, the opening is above the negative annulus. So it gives you that extra kind of additional orifice area compared to the balloon expandable valve, which are intra-annular. And this does reflect into outcomes. And this is how it is. So if you had a sort of annulus 17 to 19, you will be left with a 20 balloon expandable or a 23 self-expandable valve, which gives a better orifice area. So this is one example of body surface area is 1.81, and a 20 millimeter derived, you will get a 26 valve with no sort of gradient, but a 20 valve with gradient up to 10 to 12. So adequate unobstructed flow is important. Supraannular self-expanding gives you that, and sort of over a period of time, the difference in hemodynamics will reflect, especially in the small valve outcomes. So this case example is a 74-year-old lady, type 2 diabetic, multiple comorbidities, including previous cancer, and had episode of syncope and then multiple episodes in the hospital with a polymorphic VT. Echo showed severe AS and there was no coronary disease. And after a discussion in the MDT, obviously the initial valvuloplasties will not work for this patient. TAVI is definitely lower risk. Surgical AVR is definitely higher risk for this patient. So the consensus was to go ahead with the TAVI with a self-expanding valve. And this is the annulus derived, the perimeter derived is 19.5, area derived is 19. So it is a very small annulus and also narrow sinotubular junction and sinus of L-serva. And all the other parameters were satisfactory. The access was good. So this is how it reflects. So whenever you're selecting a valve, you want to avoid patient-process mismatch. You see what is the projected indexed effective orifice area for that valve you are choosing. Make sure it is more than 0.85 centimeter square per meter square. For this patient whose body surface is 1.6, the valve we are choosing will have effective orifice area of 1.6 and the indexed is 0.99. And the projected effective orifice area is 1.04, which is much above this 0.85. So we will not have any patient-process mismatch. And that's exactly what happened. So femoral access, the usual techniques, iotogram, the valve was crossed, valve loading was checked, and slip wire was exchanged. And very tortuous aorta, as you can see, and also very acute bend. But all this were negotiated well by the new Evolute system. You can see how it is bending. So the first position we aimed for was around 0 to 1, but there was very minimal calcification. As soon as you tried to deploy, the valve went up. So that is another additional advantage of the self-expanding. Then it was recaptured, repositioned. This time, because of the lack of calcium, it dived in. So first time it popped out, second time it dived in. So go for the third chance, and third chance we got it around 3, 4. Acceptable because of the low calcium. We accepted that, and the valve was deployed. Now this was done in 2016. It's 5 years ago. 5 years down the line, the patient is still doing well. This was in the end of 2018. The mean gradients were less than sort of 7. And now it's 5 years down the line, the mean gradient is still good. So it does prove that the structural degeneration, especially with this valve, at least for this case, 5 years down the line is still very good. So when you have such small annulus, make sure that if you're selecting a TAVI valve, you select the right valve and the right technique for deployment. And the ongoing SMART trial comparing the balloon and the self-expandable will give us more information over the next few years about the durability and the outcomes. So surgical side, they should aim to put the new generation sort of valves. There are sliding valves available so that future sort of valve-in valves will have adequate orifice area. Thank you.